Thank you. Zosha Chesteka from Medscape Oncology. Dr. Kuro, can you tell us what's the status of the drug? When might it be available? If you know, if you can say.
I think clearly the processes have started with regulatory agencies in looking at how this can be made more widely available. It really is a very exciting opportunity to change the face of oncology treatment for the future.
And can you speculate on what the indication might be? Would it be advanced cancer, all types of cancer?
So as you can see, this has been tested at this time in non-small cell lung cancer. I think that's a matter in negotiation with the regulatory agencies, but I think if one can show that these are similar populations with that same problem of advancing cachexia, where people use their own lean body mass as their major source of energy, then there is likely to be a broader view of that. That will be up to the regulatory agencies, and we wait to see their ruling.
Another question? Yeah.
Thank you.
And then here. Okay.
Sorry, Lynn Peterson with Trends in Medicine. I'm sorry I lost my place. On the ipatinib study, you gained 0.9 months, so you don't gain very much. Is this really as clinically significant? What's the clinical significance of this?
The question is for? Who is the speaker you are asking?
I'd like to ask you as the moderator, as well as the speaker, to comment on the clinical significance of these findings.
Yes.
You know, less than a month.
You will start.
So that's true that the benefit is quite low in terms of probability of response, but it's clearly there. So the challenge that we have now, we have indeed two challenges. It's to identify the patient that will respond, to more tailor the patient, because clearly there are some patients with long-term benefit from this compound. So it's really important to try to understand which are the patients that are going to respond and which are the patients that are not going to respond. The other point, very important, is that we show this benefit in a very end-stage disease. So we show activity in this patient, meaning that now we are investigating this agent in the curative setting where we have more chance to see a benefit for the patient. And I will also add to your comment that what is really important with this patient is not all time the quantity of life, but it's also the quality of life. And we are facing many problems with this patient due to the localization of the tumor, pain, swallowing problem, and clearly here we show that we can improve this in some of the patients, but I think it's the main goal that I have when I'm treating this patient.
I have also a comment on your question. It's a very good point, because yesterday in the media conference, one question was, what is really breakthrough when you select the abstract to be presented to the media? I believe in this abstract is breakthrough the point that we have a time without symptoms. You are right, the increase in progression-free survival is not so good, but think about the time without symptoms, the twist of these patients. So if you can delay the emergence of symptoms in a patient with a head and neck cancer, I believe this is breakthrough. And since this is a session on survivorship and quality of life, I believe all of this presentation provide to us something different than the breakthrough in response, the breakthrough in emerging drugs that can increase overall survival. I really believe that we neglect the quality of life of patients, and all this abstract focus specifically on this. But thank you for your question, it's very good, I believe. There, please.
Ed Sussman with Oncology Times. For Dr. Kuro, I know this wasn't a part of your objectives, but did you see a difference in survival in your patients?
The survival differences were not evident at 12 weeks, but most importantly, as you saw, there's an extension arm to that study of 12 months. Those data have just been locked, and I expect that we will see results from that in the coming months.
They can't hear you.
Sorry. Is that better?
Yeah.
So the question was, is there a survival advantage? We've seen no change in survival at 12 weeks, but the data for the 12-month extension, which was, again, double-blind, the data have been locked, and we will see those data in the coming months.
For Dr. Michels, on the afatinib study, when you set out to do this study, you made some hypothetical assumptions as to what you expected to see as an improvement. Can you tell us what that level of improvement you saw in the original hypothesis was?
So the original hypothesis indeed was met, so we aim to improve the time without disease progression in this patient. And so we powered the trial to have enough event to detect a statistical significance on that.
You didn't have a preset time that you expected to improve it by X months or 20% or something like that?
So it was an increase in 20% in the relative risk of disease progression. And this was met, and after you have secondary endpoint, it was survival and it was the quality of life.
Right, okay, please, so the question here. Okay, here, there's a question.
Yes, hello, Jacob, please, from EP Vantage. A few questions for Dr. Currow, please. Firstly, on a technicality, did either of the Romano 1 or 2 studies demonstrate statistical significance individually, or is it only when you combine them that you get high enough patient numbers to hit significance?
As we saw from both sets of graphs, each of them has statistical significance in and of itself. Both were powered, both adequately recruited to their full complement, and both of them independently showed statistical significance. Thank you for the question.
Okay, great, thanks. I suppose one of the criticisms of this study, I suppose, of the data is that all you've shown, maybe, is that you can get patients to put on weight rather than fundamentally affecting the muscle wasting. So I wonder how important you think it is that the co-primary endpoint in hand grip strength was missed.
I think it's very early days to see a change in hand grip strength at 12 weeks. What we have seen, most importantly, is that lean body mass has changed, and I think this is a generational change that we're seeing. We've seen drugs before that can add body mass that wasn't just edema, but this is the first time that we have systematically and consistently seen a signal for lean body mass. This is a generational change.
Okay, and in these side effects, I note you saw some hypertension and some hypoglycemia and diabetes. I wonder how controllable these were and how important you see these as being.
Importantly, I think this reflects ghrelin, and it was an expected effect. It was one we specifically sought, given the mechanisms of ghrelin and a ghrelin agonist. The numbers with hyperglycemia, that was well controlled, and a very small number of people had overt diabetes. Again, easily controlled, looked for prospectively, can be managed clinically.
How was the diabetes controlled?
The last question for you.
Sorry, did any of them go on insulin?
As you would control anyone else with diabetes, depending on the severity of that, so either insulin or oral hypoglycemics.
Okay, another question here. Yes.
Charles Bankhead, MedPage Today. I have a question about the afatinib study. Were the patients evaluated or assessed with respect to HPV status? And if so, did the results vary by HPV status?
So that's true that HPV is a cause of head and neck cancer. So most of the patients in this study were patients with head and neck cancer induced by alcohol and tobacco. We have a subgroup of patients with HPV positive disease, around 10%. It's looked like the benefit of this compound is lower in this group of patients. So maybe because it is I use maybe because this is a subgroup analysis, but in patients with disease induced by tobacco and alcohol, the benefit is higher. But we need to be careful because when we are doing it to go to subgroup, the number of patients could be very small.
Any other question? Yes?
Dan Keller, News for Med. For Dr. Rappaport, do you see advantages of rolapitant over aprepitant, either in pharmacokinetics or efficacy or anything? And in practice, how do you see it being used? Do you see something else being added for the acute phase, dexamethasone, ondansetron, anything like that?
Just ask me the question again.
The first part was, do you see an advantage over aprepitant for rolapitant, either in pharmacokinetics or efficacy? And do you see it being used as a pre-medication to chemotherapy? And would it be used with any other drugs for the acute phase, such as dexamethasone or ondansetron?
It's a very technical question. It's a comparison between two drugs.
Okay, let's go one by one. The first one is, I mentioned that there is a different compound because it's not an inducer of a C3A4, so you avoid the drug-drug interactions, number one. The second thing is that over 5 days you have up to 5 days you have receptor occupancy as opposed to the other ones that have only 24 hours, number two. And number three is an oral medication. You give it only once at the dose of 200 milligrams, and it goes for the whole period of CIMB for 5 days, 5 to 7 days. So you can give it once, as I mentioned, and it's a very convenient compound to use also. Now, in terms of the acute phase, you have to, as you know, there are two pathways. One is the serotonin pathway, and the other one is NK1 pathway. The serotonin pathway is primarily dealing with the acute phase, so you have to use drugs like granisetron or palonosetron or ondansetron to control that, together with corticosteroids. And then for the delayed phase is exactly where it works, NK1 receptor antagonist. So, and this one is an excellent NK1 receptor antagonist. In order to know if it's, to me, it's going to go to clinical practice for sure, for treatment of HIC, and for AC type of MEC chemotherapy. HIC stands for highly emetogenic chemotherapy, and MEC stands for moderately emetogenic chemotherapy. AC type is adriamycin cyclophosphamide for patients with breast cancer. It's debatable, and according to guidelines, if you should use it on the other type of non-AC. I have a couple of publications on that deals with the matter. It's a big group, the MEC. Some of them are more highly than lower emetogenic. It's between the chance of having nausea and vomiting is between 15 to 75%. So some drugs are more to the HIC side, and the other ones are more to the low side. So that drug is for sure is going to be used in clinical practice. Now, to say if it's better than the other compounds, you still have to do a randomized trial between the two of them, and I don't know if it's going to happen that.
Okay, question there and then here.
Frédéric Soumois Le Soir for the Professor Amand. Did your results signify that the actual guidelines for pregnancy and cancer will change all over the world, or the number of the patients and infants is too low to change the guidelines?
I didn't understand very well, but it's about guidelines and whether these numbers are high enough to change the guidelines. And then the current treatment. I think you're right, we have to be careful. The children are quite young, and the numbers are not that high. That's a good point. However, if you examine these children at this age of 18 months or 3 years old, and they do well, this is a strong prognostic factor for later on also doing well. And we also have data, but these are not data that we present here. We also have data from children who are older, not with case controls, but in fact also these children, when compared to normative values, they do actually well. So definitely we believe that, and at least that's what is happening in Belgium and at this stage, is that there is a clinical change in how we approach pregnant women dealing with cancer. And that it is less offered first to, it happens less to offer them first termination of pregnancy and subsequently proceed with cancer treatment. So we definitely feel that there is place to change clinical management, and we should not offer any longer pregnancy termination. We really believe that we can treat with cancer during pregnancy, and that we can prolong, that we can leave the fetus as long as possible with the mother. And that's actually one of the strongest messages, because what was used before is a mother is 32 weeks of pregnancy, then they say the patient is viable, so let's deliver the mother and treat the mother. But we have to make a difference between viability and maturity. If a baby is viable, he will survive, but he will have some consequences, and sometimes severe consequences, long-term, of prematurity. And that is actually where with chemotherapy, we can actually prolong the period that the baby is with the fetus. I can assure you, and I can all assure you, if you put 10 children on a row and 2 have been antenatally exposed to chemotherapy, you will not be able to see what child actually received cancer treatment in utero.
Professor Aman, can you do a short comment on unplanned pregnancy during chemotherapy for young women? So if you are getting chemotherapy and you are a young woman and you got pregnant, what do you have to do?
Well, that's a very difficult one, because one of the reasons why it is safe, actually the reason is twofold. First, we give chemotherapy after the first trimester of pregnancy. This is the proportion of children that we have shown. And secondly, the placenta filters actually. The placenta is an active organ. The placenta has transporters that actually capture the chemotherapy. Chemotherapy is a large molecule, and therefore in all drugs that we tested, always there is to some extent prevention of passage towards the fetal compartment. For taxanes, it's 0 to 1%. Iprubicin, doxorubicin, 4 to 7%. Carboplatin is in our hands has the highest passage of about 60%. But always it is less chemotherapy that reaches the fetus when compared to the maternal compartment. This is, now I come back to your question. If you are getting chemotherapy and it's an early pregnancy, well, then we have to be very careful, because the first stage of pregnancy is the stage of the organogenesis. So that means that all the organs are formed. And there are data that suggest that the incidence of congenital malformations is higher if you expose these pregnant women to chemotherapy. So a patient that really becomes pregnant during chemotherapy, that's a real problem. And our data do not say that this is safe. But you point towards another issue. We have a poster that will be presented on Sunday about fertility or about contraception. And in our series, we had 29 women. It's only 3% of the population, but actually contraception was not discussed. So also for oncologists, that should be a point of discussion in young women who get cancer treatment, that contraception should be a point to avoid the difficult situation you're referring to. You're getting cancer treatment and then you become pregnant.
We have the last question.
It's a quick related question. Are you, Susan Mayer from the UK, are you carrying on following up the children in your study to look at later possible effects? And if so, what would you be looking out for?
Well, we look, I hope I understand, it's about the long-term follow-up. So this is indeed what we present as a case control study in young children, but we do continue the follow-up on all these children. We continue to follow up until the age of 18 years old. We look then to attention, to behavior, to memory, verbal, non-verbal memory, and we have a checklist on behavior that is completed by the parents, and we have a general checklist on medical problems. We look to the intelligence of these children, and we continue to look to the heart function, and this until the age of 18 years of age.
So thank you very much. Our speakers are available for other questions. Just to summarize, so we have a very good drug, rolapitant, for the treatment of nausea, vomiting. Anamorelin is a new drug for treatment of anorexia, cachexia. Afatinib for the treatment of head and neck squamous cell carcinoma. And finally, we had a very good discussion on pregnancy and cancer in very young women. So thank you very much to everyone. Grazie.